I prepared the clinical vignette session and I tried to make it as intellectually challenging as I could around the field of red cells. I think actually red cells is so exciting these days, and there are so many areas we're advancing at a very fast pace that I think we captured that in this session. So we had three areas. The first was the effect of daratumumab on cross-matching, and it does produce a pan-agglutinin, and unless those in transfusion know about it, then it's quite difficult to cross-match. And the poor guy who was presenting had to go through the houses to find out what was going on, and if someone had just told him straight away, then it would have been easier. And the second was a case of hyperhemolysis in sickle cell disease, who had all sorts of therapy and actually had eculizumab and rituximab, intravenous gamma globulin, hydroxycarbamide. And the question is, what do we do with him now? And there's quite a good discussion in the audience about where we go. And then the last case was David Rees, who specializes in inherited difficult anemias. And this was a case he'd followed up for 20 years and never got to the answer to. And then finally, they sequenced huge areas of the gene and they found a defect that is newly described. It doesn't cause any long-term harm, but may well be found in quite a lot of other conditions where they're mimicking maybe pyruvate kinase deficiency. The NICE guidance on thromboprophylaxis has just been reissued, and it's 2 years of hard work. It's called NICE Clinical Guideline 89, and we have gone through all of the papers on thromboprophylaxis again. And so there's some minor differences in the use of pharmacological thromboprophylaxis in all areas, but really the biggest change is that since we last did the NICE guidance, there's now quite a lot of evidence saying if you use intermittent pneumatic compression, it's actually got a positive benefit. There's reduction in the rate of DVT and PE. These are mainly surgical studies, but we have extrapolated them across. And what's become very evident is that anti-embolic stockings, which cost the UK about 63 million a year, really have a very poor evidence base. And so they've been downgraded quite a lot. So when we suggest mechanical thromboprophylaxis, we're suggesting intermittent pneumatic compression. Currently we've got a trial going called the GAP study, and we're trying to randomize 3,000 moderate risk patients who are having surgery. They get pharmacological thromboprophylaxis, and then underneath they get stocking versus no stocking, and we're looking for the rate of DVT and PE to see actually, do stockings give a benefit? We're halfway through at the moment. It's looking very exciting.